A 36-year-old woman comes to the outpatient clinic after noticing a small lump on the front of her neck while looking in the mirror. She says she first felt it a few weeks ago, but it seems to have grown slightly in size. She denies pain, difficulty swallowing, or voice changes, but mentions a mild sensation of fullness in her neck when she lies down. On examination, a firm solitary nodule is palpated on the right lobe of her thyroid gland. It moves with swallowing, and there is no obvious tenderness. There is no cervical lymphadenopathy. Her vital signs are normal, and she appears calm but concerned. Thyroid nodules are common, but the key in evaluating them is identifying which ones may be malignant. The first step is laboratory testing. Her TSH level is measured and comes back normal. With a normal TSH, the next step in evaluation is imaging, specifically a high-resolution thyroid ultrasound. Ultrasound shows a 1.8 centimeter solid hypoechoic nodule with irregular margins and microcalcifications, features that raise suspicion for malignancy. The radiologist categorizes it as TI-RADS4, indicating moderate suspicion. Given these features and its size, the recommended next step is a fine needle aspiration biopsy, or FNA. Under ultrasound guidance, a thin needle is inserted into the nodule to obtain cells for cytologic analysis. The results return as Bethesda Category V, suspicious for malignancy. This category carries a high likelihood of cancer, most commonly papillary thyroid carcinoma, which typically has an excellent prognosis when treated early. From a surgical perspective, the patient is counseled on management options. Because the nodule is suspicious and over 1 centimeter, surgical removal is recommended. Depending on the size, location, and risk factors, the surgeon may perform either a lobectomy or a total thyroidectomy. In this case, with a solitary 1.8 centimeter nodule and no evidence of lymph node involvement, a thyroid lobectomy is appropriate and preserves more thyroid function. During surgery, the priority is to safely remove the affected thyroid lobe while protecting the recurrent laryngeal nerve and preserving the parathyroid glands. Post-operative recovery is typically smooth, and most patients go home within a day. Key takeaway: evaluation of a thyroid nodule centers on TSH testing, detailed ultrasound assessment, and FNA biopsy. Suspicious ultrasound features and high Bethesda categories guide the need for surgical management. Early detection and timely surgery offer excellent outcomes in most cases.